Well, good afternoon, everyone. Thank you so much for being here. My name is Megan Collette. I'm the behavioral health consultant for the Michigan Opioid Collaborative, and I serve the Western region, including Livingston, Hillsdale, and Jackson County. We are so grateful that you're here today. We're excited to present our webinar on post x-waiver, improving buprenorphine access at the community pharmacy. We're super excited for our presenter and for a very involved discussion today. We actually have the opportunity for 4 different continuing education credits today. The QR code that you see on your screen now is for CMEs for medical professionals, CEs for social workers, and also for those looking for MCBAP credits. And then at the end of our discussion today, we will be presenting a QR code for those looking for pharmacy CEs. We are very excited to have that opportunity to offer to our PharmDs in the group today. And so we'll be sharing that. And then all of our QR codes will be emailed to each participant once our webinar is completed today. All of the QR codes, I believe, expire within 48 hours. So please make sure to scan and complete that process within that 48-hour time period. And as always, if you have any questions at all, we have someone in the MOC team who's able to help navigate those challenges if you should need any assistance. So we are going to get moving. I'm going to share just a brief overview of kind of what we do here at the Michigan Opioid Collaborative. For those that may be joining us for the first time, welcome. For those that have joined us before, we encourage you to share our information and our website with those that you work with, your community members at large, and your family and friends as well. So the Michigan Opioid Collaborative is an interdisciplinary team supporting providers and communities to increase access to office-based addiction treatment, expand care, and improve quality of care with patients with opioid and other substance use disorders throughout Michigan. Michigan Opioid Collaborative is grant funded through Blue Cross Blue Shield and MDHHS. We offer free same-day consultation services to help provide evidence-based quality addiction treatment. Our team of specialists are available to help with patient case questions related to treatment and management of substance use disorders. Michigan Opioid Collaborative offers quarterly introduction to buprenorphine trainings, as well as other webinars, such as today, on a variety of educational topics, such as addiction, stigma, and substance use. We also have a hepatologist on our team who offers Hep C treatment consultations within 48 hours. She facilitates a bi-weekly case consultation webinar to review cases with providers and has developed a 3-part webinar series on HCV treatment. We also have created toolkits for providers that are on our website. We invite you to check us out and click through all of those links for having some more resources when treating patients with multiple SUDs. The Michigan Opioid Collaborative also has behavioral health consultants around the state that are happy to help facilitate trainings, answer your questions, troubleshoot with technical assistance, and also be an extra support to you, your organization, and your community. Please, again, take a look at our website for our events and feel free to contact us with any other information that you may need from us. And with that, we're going to go ahead and just get going. We're very excited to have Dr. Tutag Lair here with us. She is a professor of pharmacy practice at the Eugene Applebaum College of Pharmacy and Health Sciences, Wayne State University, Detroit, Michigan. She is the clinical pharmacy specialist in pediatric pain management at Children's Hospital of Michigan, Detroit Medical Center. Dr. Tutag Lair received her Bachelor's of Science in Pharmacy from Ferris State University and her Post-Bachelor's Doctor of Pharmacy from Wayne State University. She has practiced in a variety of roles in community pharmacy to health systems administration. Upon entering academia, she held a joint position in protocol development and teaching with the NICHD Pediatric Pharmacology Research Unit at WSU CHM. Dr. Tutag Lair served for 8 years as chair of the MDHHS Pharmacy and Therapeutics Committee, where she participated in implementing the Michigan naloxone standing order and improving access to buprenorphine during pregnancy and the postpartum period. Dr. Tutag Lair is a funded, published researcher in pain management, opioid use, and overdose prevention. She collaborates with the WSU Center for Urban Studies to improve naloxone and buprenorphine access. The Michigan Opioid Collaborative could not be more excited to have her join us today for our webinar on post x-waiver improving buprenorphine access at the community pharmacy. And with that, Dr. Tutagler, I would love to turn it over to you.
Well, thank you, everyone. Thank you, Megan, Ashley, and the rest of the Michigan Opioid Collaborative team. I'm so excited to have such a large turnout today. Thank you, everyone, for setting some time aside to talk about how we can improve buprenorphine access at the community pharmacy post x-waiver. Just some housekeeping. I have no conflicts to declare. And again, thank you, Ashley, Melissa, and Megan, for your support and funding this webinar. I will discuss some off-label use of buprenorphine. And also, thank you to my colleagues at the Michigan Pharmacists Association for navigating the ACPE continuing credits for pharmacists today. The objectives are here. I'm not going to go through those in sake of time, and hopefully you saw the objectives when you registered for this program, and these are what led you here. Let's take a check-in here of opioid use disorder with respect to third quarter 2023. What is going on? While we are seeing an increase in high-potency synthetic opioid exposure and overdoses combined with stimulants and the very dangerous animal tranquilizer, the potent alpha-2 agonist xylazine, we are seeing too about 10%, 9%, depending on who you read, of the fentanyl exposure coming from counterfeit prescription pills. This is a big item lately in the lay press. You can see NPR had a podcast about U.S. drug overdose deaths caused by fake prescription pills. And these fake prescriptions or counterfeit prescriptions are primarily oxycodone, Adderall, and Xanax. Our overdose deaths nationally tap out here at about 110,000 a year, depending on who you read. This is from the CDC 2022 provisional data. And in Michigan, we're right around 3,000. That's a decrease from the year prior. However, no time to throw a party because we are still in the top 10 states with respect to overdose deaths. We have an addiction treatment gap where only 1 in 5 persons with opioid use disorder have access to medication treatment. This was published recently in JAMA 2023 and also documented by a national survey by SAMHSA. And if you are Black, female, unemployed, or living in a non-metropolitan area, you have a higher likelihood of not being able to access medication treatment for OUD. What does this all mean? This means we have an urgent call to expand treatment access. Going back to xylazine. Xylazine exposures in deaths involving illicit manufacture fentanyls have increased almost 300% from January 2019 to June 2022. So as of June 2022, you can expect about 90% of all of the illicit manufactured fentanyl deaths to have some co-involvement or detection of xylazine. Xylazine is particularly dangerous when combined with an opioid because xylazine prolongs the opioid anoxia and makes it more difficult to reverse the opioid-induced respiratory depression. Chronic xylazine use also causes ulcers. I didn't bring any slides today because I thought some of you may be eating lunch during this time. And persons are coming in with sepsis, skin necrosis from xylazine-induced ulcers. It's extremely dangerous. With respect to our state, xylazine's right in our backyard. Depending on where you are in the state, xylazine is involved in 50 to 75% of deaths from illicit manufactured overdose. Xylazine has no human indication. It is an animal tranquilizer. There is some legislation pushing to have xylazine designated as a Schedule III controlled substance. Will that slow its use on the illicit drug market? Maybe, maybe not. The Kaiser Family Foundation noted that 2/3 of adults have been impacted by addiction, either personally or within their family, from a survey in July of 2023, just this summer. So individuals can no longer say, opioid use disorder, overdose doesn't affect me. 9% of these individuals have reported a family member who have died of an overdose. Our students here at Eugene Applebaum College of Pharmacy reported during a survey that we gave them during naloxone training, 10% of them reported having been involved in an overdose situation in the community. So the time is now to prepare everyone to respond to an overdose and to promote access to overdose use disorder treatment. Just briefly, we need to look at the medications for opioid use disorder. There's 3 medications available in current practice, and they all interact with the 3 main opioid receptor subtypes to some variation. What's really exciting is that there's been polymorphisms or allelic differences in pain that confer pain sensitivity, differences in depressive symptoms, and alters reward processing in these opioid receptors. These opioid receptors are simply gene areas that are G protein coupled receptors on the protein on various parts of the CNS. What we want to look at is the differences in our treatment modalities. We have the full agonist, methadone, which in increasing doses increases the opioid effects of euphoria, respiratory depression, and sedation. There's no ceiling to these effects. And also, secondly, we have here the partial agonist, buprenorphine, which has an partial agonist at the mu receptor. Doesn't mean it's less potent in treating opioid use disorder, because it binds very tightly to the mu receptor, and it is extremely effective because of slow dissociation from the receptor in preventing with recurrence of withdrawal symptoms. Last but not least, we have naltrexone, which is available in tablets and in IM form, which is an antagonist at the opioid receptors. Completely blocks, competitively blocks the opioid receptors, blocking euphoria, blocking respiratory depression, sedation, reversing the effects of any opioid, endogenous and exogenous. And then we have naloxone, which is used to reverse in an emergency situation or in a clinical situation when we have respiratory depression, sedation in an overdose or as adverse effects. Focusing now on buprenorphine for opioid use disorder, this partial opioid mu agonist is a Schedule III controlled substance. It's been around a long time. If you're an older or senior, more senior clinician as I am, you're used to seeing it ordered for moderate, maybe severe pain. It's been around as an analgesic since 1981 and was first approved for OUD in 2002. It is first-line treatment for opioid use disorder. Patients no longer, or individuals no longer have to fail methadone or a 12-step program or go through other treatments to be initiated on buprenorphine. It is first-line treatment, and it is continued indefinitely throughout the continuum of a patient's life or an individual's life, because opioid use disorder is a chronic, recurring disease or condition. The advantages are, when you initiate buprenorphine, you see rapid improvement of the withdrawal symptoms. And because of its slow dissociation, you see a sustained effect of maintenance. The advantages over methadone, which is available only in or through a federally certified treatment program, is that buprenorphine can be prescribed in the community by any provider licensed to prescribe controlled substances. And it can be dispensed by any community pharmacy that has a controlled substance license and dispenses other controlled substances. So it is a destigmatized type of opioid use disorder treatment. And for most payers in this country, it is a covered pharmacy benefit. The Mainstreaming Addiction Act, signed into law in December 2022, it's a piece of bipartisan legislation, eliminated the federal Data 2000 or data waiver, the x-waiver program that had buprenorphine prescribing limited to only certain providers that were registered with the DEA and had undergone special training and had an x-waiver DEA number. This legislation also removed treatment caps or limits. Previously, providers could only treat a number of patients per year with buprenorphine. And now any provider with a standard DEA number can prescribe buprenorphine just like any other controlled substance. Now, what did this do with respect to buprenorphine prescribing? Nationally, there's not been a significant increase in the number of buprenorphine prescriptions since the beginning of the year. Is it too soon? This is what some of our researcher commentaries are saying. Maybe it's too soon to track. We looked at this in Michigan. I just looked at MAPS data in number of prescriptions dispensed. There is not a significant increase as well. Maybe it is too soon to tell. Maybe fourth quarter will tell us something about an increase in prescribing. Part of this act was that all controlled substance prescribers must undergo, at the time of their DEA registration or renewal, a one-time 8-hour training. Telehealth. Telehealth was revolutionized during the pandemic. This was an interesting quote from the National Academy of Medicine. They said that the pandemic that ravaged the world may have jump-started the telehealth revolution. which is true. And telehealth was really the exception instead of the norm before the COVID-19 public health emergency that removed stigmatizing policies for treating opioid use disorder. So telehealth allowed clinicians during the COVID pandemic public health emergency to prescribe buprenorphine, initiate buprenorphine using audio visits only. When telehealth ended, there was an outcry from, when the public emergency ended, there was an outcry from clinicians and the public to extend the prescribing ability using audio only. And the VA system results support use of telehealth via audio only, showing that the majority of their buprenorphine telehealth initiation visits each month were audio only, and that persons who received greater than one telehealth visit were more likely to stay in treatment 90 days, though, compared with those who had an in-person visit only. Audio visits only, if you think about it, offer flexibility, especially for those individuals with unstable housing, no computer access, and no access to high-speed internet. The DEA extended the telehealth prescribing for controlled substances 2 days before the expiration of the COVID public health emergency. The rule was extended for teleprescribing of controlled substances, including buprenorphine, through November of this year. And if you have an existing provider telemedicine relationship, that's extended through November of next year. The DEA is reviewing comments, hundreds of thousands of comments regarding these stricter rules. One of the rules imposed that may be imposed is to limit a 30-day initial prescription after an audio or telehealth visit. Now, there's no evidence that teleprescribing of buprenorphine increases diversion or overdose. Conducted studies, one in JAMA recently has shown there's no evidence that the teleprescribing via audio only during COVID has increased diversion or overdose involving buprenorphine. The proportion of overdose deaths during the 15 months where telehealth was prescribing was relaxed it fluctuated, but did not change. It averaged from 2.2 to 2.6% of all opioid overdose deaths over that 15-month period, which is testament to the efficiency and safety of telehealth prescribing for buprenorphine. We talked about, some of the prescribing barriers are being removed, but what about the pharmacy barriers? There's many pharmacy level barriers to buprenorphine. There's reports from patients, providers, pharmacy interns. As a pharmacy educator, I get calls several times a week. What is wrong with your pharmacist? Provider colleagues call me and say, my patients still can't get their buprenorphine at X pharmacy. What is wrong? Why are pharmacists so stigmatized? Why don't they want to work with us? Why are they afraid of these patients? I've had students stand up in class and say, my preceptor told me that they don't want to deal with these patients. Just say, no, we don't carry buprenorphine. Partners, funders, stakeholders have reached out to us asking, can we do seminars such as these to explain how pharmacists can work together with the rest of healthcare professionals and the team to improve access? What are the barriers? How can we strategize to decrease them? There's been several publications that have highlighted the different types of barriers, and they're not decreasing in number, unfortunately. The one that really rocked our world as pharmacists was one by Dr. Cooper. She is a public health researcher, and this was in New England Journal of Medicine in late 2020. She talked about regulatory barriers such as wholesaler limits. Pharmacists will often say, I'm at my limit. I can't order any more buprenorphine. Buprenorphine for OUD is included in the pharmacy's wholesaler controlled substance limit. And the wholesaler sets limits for each pharmacy with respect to controlled substance ordering. And the DEA doesn't set the limits, but the DEA monitors the wholesaler distribution of controlled substances to each pharmacy customer, if you will. And if you exceed your usual purchasing, you are at risk of an inspection from the Department of Justice or DEA if you do not have legitimate prescriptions to support the use. The best thing to do is, if you have new providers in your area prescribing buprenorphine, contact your wholesaler and ask for an increase in your limit. Work with the wholesaler. Or if you have several pharmacies in your area that are providing more buprenorphine because an increase in legitimate scripts are required because you have more providers, all get together and petition the wholesaler together. That's one strategy to circumvent the wholesaler limit barrier. Regional variability does vary. Unfortunately, of buprenorphine in our southern states in Appalachia, where overdoses are at high rates, many pharmacies do not carry buprenorphine. There's a mismatch in supply and demand. We found that rural areas in Michigan compared to urban areas in our recent pharmacist statewide survey, Claire Nolan and myself, we found that we have increased rural availability in Michigan. It was the opposite for our state. Practice site can vary. Independent pharmacies will often have barriers in availability compared with chains. There's diversion concerns. Several pharmacists, even in our state, in our survey, will say they're concerned about crime and diversion associated with buprenorphine. If you read the literature, you will see the majority of diversion of buprenorphine is related to individuals sharing their medication with significant others, relatives who are waiting for access to treatment or who cannot afford access or who have barriers to accessing treatment. So, way to decrease diversion may be to improve access. There's quite a bit of stigma with respect to buprenorphine and caring for individuals with opioid use disorder. We often do scenarios in teaching our students. Would your response be different if that prescription was for an antihypertensive or an antidepressant? At times, pharmacists will lack confidence in provider and patient interactions. Opioid use disorder is a relatively new topic or area of practice in healthcare, and many practitioners may not have had the support in our knowledge. And we found that attending ACPE, continuing education forums, or working with mentors, or attending interprofessional types of role-playing increases confidence in pharmacists interacting with providers and patients. And some pharmacists said there's limited availability of providers in their areas, and they have issues when they try to speak with the provider. There's a lot of barriers with clinical staff or the front desk. They're unable to reach the provider to clarify prescriptions or verify prescriptions. A recent provider prescribing survey that was published last spring by MDHHS and Laura showed that the providers in Michigan, this was when we still had the x-waiver program or regulations, showed that the recommendations were to increase providers in our state and in the rural and northern areas, and encourage treatment prevention. When someone misses an appointment or is late for a refill, do we treat them punitively, or do we try to improve access or work with them and strategize how to improve their adherence? And episodes of recurrence, how do we address those? Are we punitive or are we supportive? Excuse me. Increasing community outreach, decreasing stigma, and improving equitable treatment is an urgency as well. Facilitators would be over half of the respondents. The providers said they would like pharmacies in their areas that they can collaborate with to dispense medications for opioid use disorder. This would really help facilitate them in prescribing more buprenorphine. And barriers, the usual issues. My patients have difficulties in filling prescriptions, and pharmacies are unwilling or unable to fill buprenorphine prescriptions. Secret shopper studies have been conducted throughout time. This recent one of over 5,000 pharmacies on the behalf of almost 4,000 patients, the researchers called on behalf of their patients enrolled in a program, a variety of pharmacies throughout the country, and asked if they carried a specific type of buprenorphine naloxone. And they found that chains were more likely to report availability over the phone than independents. Florida had the least availability. Washington State had the most. In Michigan, we were about halfway there. And again, pharmacy availability is a barrier to access. A limitation, though, is that the researchers did not go and follow up to see if the pharmacy was able to order the prescription or if they were really speaking to the pharmacist. So those were some barriers. Claire Nolan and I conducted a survey of the state's community pharmacists. We published in the Journal of Addiction Medicine, where we're really excited because we were able to reach out to a variety of professionals caring for persons with opioid use disorder. And we found that 80% of our pharmacists who responded stated that they practice at a community pharmacy that dispenses buprenorphine, and in contrast to other reports in other states, a percentage of pharmacists in rural areas compared with urban responded yes. And more pharmacists at independents versus chain said no, which is similar to other researchers. And again, the value of continuing education on pharmacists is demonstrated here. Pharmacists who had reported having some type of ACPE, accredited continuing pharmacy education programming on buprenorphine and OUD showed higher knowledge scores, decreased stigmatizing perceptions, the increased likelihood. These pharmacists were more likely to confirm the availability of buprenorphine over the phone, and they had more confidence. They self-assessed them as more confident in interacting with the providers and patients. I'd like to go through our first assessment now. And these are pharmacy-based, so if the other participants, the providers, and other team members can just bear with me. Let's say you are a pharmacist practicing at a community pharmacy, and you hear a pharmacy technician inform a young male patient who you do not recognize that the pharmacy does not carry buprenorphine naloxone film strips. And you know you have this product in stock. Now, what is your most appropriate action? We will give you a few seconds here, and if someone would type in the chat, and Megan and Melissa will take a look at the chat.
Yeah, we have a few questions for the group, and so we'll take answers in the chat, and so you don't have to unmute or make your video show. We have some answers for section for choice C, is what we're getting from some folks. Yeah, lots of C's so far.
Good. Well, C, okay. All right. Yes. The most appropriate action would be to talk with the patient, review the prescription to determine whether you can fill, meet with the tech after to discuss the role and possible stigma toward OUD. The key points, the pharmacists, as pharmacists, we have a critical role in ensuring continuity of OUD therapy, just as we would for a person with diabetes, cardiovascular disease, cancer chemotherapy. We have to look at this as another chronic type of condition. We expect persons with recurrences for chronic conditions. We would expect this too with opioid use disorder. Stigmatizing perceptions, we know from the literature and from experience, can affect access to buprenorphine and treatment outcomes. At the worst, they can cause withdrawal, recurrence, and we need to look at the origins of stigma. Have we had a negative experience with an angry, unpleasant patient? Sometimes individuals are frustrated, angry, afraid, and they lash out. It is difficult. Specific education is available. There is a great paper by Sarah Sev, specifically aimed toward pharmacy technicians, talking about stigma and compassion fatigue when you're at the front line, when you're the face of the pharmacy, taking the initial information from the patient. It can be difficult, can wear you down. I'm sure office staff or clinic staff feels that way as well. And what we found is a great resource is to do some interprofessional teaching with a recovery coach. My students in my pain management elective found really insightful strategies from having a recovery coach come in and talk with them about their experiences coming to a pharmacy while they were even before they were in active treatment, when they came in with an antibiotic for cellulitis, and how they were perceived their treatment. So there you go. Great job. Assessment number 2, a primary care practice near your pharmacy begins prescribing buprenorphine for opioid use disorder. The volume of your buprenorphine prescriptions increases by greater than 30% over several months. That's great. But then you receive a notice from your wholesaler that you are exceeding your usual purchases. What's your most appropriate action? I just had a pharmacist call me about something similar the other day, and so it does happen. What do you want to do? Anyone in the chat?
Oh, we have some A's coming in. Lots of A's. Some more A's.
All right. Well, we're going to go with the A's. Yes, that would be your most appropriate action. Work with the wholesaler. I know several pharmacists don't know this is an avenue or a strategy that's available to us. And if you're part of a chain, you have to work through your management and your district manager, though this is something that's within our professional prerogative and our ability to move ahead and do. So primary care providers are increasingly providing OUD treatment services in the community. It makes sense that OUD screening is conducted, annually, or many patients or individuals present to their primary care provider with signs and symptoms of OUD or OUD-related adverse effects. So you may see an increase in volume in buprenorphine prescriptions. And you can request an increase in work with your wholesaler because you need to meet the prescription requirements of your population. Now here's the next one, and we do have Dr. Poland who is one of the national, she's in our audience, I saw, and she's one of our national experts on treating substance use disorder in pregnancy. So I'm happy she's with us today. This is a case where you have a visibly pregnant patient dropping off a prescription for buprenorphine naloxone films. You review her MAPS report. You note that she's been taking this dose for several years, yet she is 2 weeks early for a refill. What's your most appropriate action here?
We've got some C's coming in.
Okay.
We have an A in there, thrown in there too. Mostly C's, it looks like.
Okay.
C.
Wonderful. Very good. Well, the C's have it. Contact the prescriber, notify the early refill request, ensure the pregnant patient has medication to prevent withdrawal. What would be a disadvantage or a risk of waiting to inform the patient when they return? Anyone?
You say that one more time?
A potential disadvantage or risk of waiting to inform the patient when they return that it's too early for a refill. Call your physician.
Nobody's brave.
Okay. What if the provider doesn't know the patient's pregnant? What if the patient returns late or the next day?
We have a couple things baby could withdraw, maybe giving it to family members, like a diversion may go through withdrawal.
Yes. Okay, right. You don't want to ever leave a patient without adequate medication supply. And patient is pregnant, right? You have the maternal fetal dyad you're working with. What is the risks to her unborn baby if she withdraws? Anyone?
We have death in the chat.
Well, possibly, right. It'd be fetal stress, right? Okay, well, some important points. Some pharmacists on our survey did not know that buprenorphine is safe and effective during pregnancy for opioid use disorder. Another reason that pregnant patients may have increased use of their buprenorphine and comfort early refills is that they're using it more frequently. They may find that as the day wears on, they need to increase their dose or the frequency because pregnancy can increase the metabolism. They can have larger volumes of distribution. There's some great papers out there. I believe Manning is one that showed their cohort of pregnant patients that they increase starting in the second to third semester, extending out to 12 weeks of postpartum. The dosage or the frequency of dosing, many patients need to split their dose. And during pregnancy, to prevent return of like anxiety, patients would say, you know, end of the day, I'm starting to get antsy. And I noticed it's since I've been pregnant. And there is quite a bit in the literature about increased buprenorphine requirements during pregnancy. So you need to contact the provider. Make sure the provider knows the patient's pregnant. Talk with the patient too when they return. It's very important to start the conversation with the patient. Ask them what's going on. And you need to ensure that buprenorphine is continued, their therapy is not interrupted, basically for any patient, but particularly for the vulnerable pregnant patient to avoid adverse maternal fetal outcomes. You want to avoid withdrawal, which is a great stressor on mom, but a higher stressor on the unborn baby. And withdrawal during pregnancy can trigger premature labor. I have had providers who care for pregnant patients during pregnancy, treating them for opioid use disorder, having to admit their patient to maternal fetal medicine units over a weekend because pharmacists have refused to fill their buprenorphine prescriptions or have not had adequate medication in stock and would not do a partial fill, or who have not assisted the patient in finding adequate medication, or one case, the pharmacist could not verify the script, even though this provider was well known in the area, and refused to fill. Patient went into premature labor and was hospitalized. So this was another one of those, what is wrong with your pharmacist calls? They're becoming less frequent, and the area of buprenorphine treatment during pregnancy is becoming well described in the literature, and we do teach it throughout our pharmacy programs. But great job. Any other questions on that piece?
We just had one pop in the chat. Do prescribers need any additional educational training before prescribing Sublocade?
Sublocade, there's a REMS program, and it's dispensed by, and that is the Sublocade is the sub-Q long-acting injection. And there is a program where the providers need to register and also work with a specialty pharmacy to have that drug dispensed, that medication dispensed. It's a sub-Q form of buprenorphine, and it is administered by a provider. It's not dispensed directly to the patient. Minimally, it's given every like 26 days, like usually every month. But there is additional, training from the REMS program.
Great. That's the only one so far. We have just a
Okay.
few minutes left, so we'll
All right. Assessment 4, you receive a prescription for a 26-year-old male for buprenorphine 28 milligrams, 7 milligrams of naloxone per day. This dose is higher than you think is safe. And you see the FDA max is 24 milligrams a day. What's your most appropriate action here?
I see some D's coming in. Some B's and D's, B's and C's. So we have B's, C's, and D's.
Okay. All right. Well, let's see. Well, the B's and C's are both correct. That's your most comprehensive course of action. You want to contact the prescriber, verify the dose, and then check maps, of course, and obtain a history from the patient. There are select patients that may require higher dosages up to 24 to 32 milligrams a day, particularly those with illicit manufactured fentanyl use, or if the patient may have a delay in follow-up care. Many times there's high induction protocols a patient may be taking part in. Patient may be an ultra metabolizer. Buprenorphine is metabolized primarily by CYP3A4 and 5 hepatic microsomal enzymes. Some of those are genetically determined. We can phenotype and find out as well. And it's not unusual to see 24 to 30 milligram doses of buprenorphine a day. They're associated now with higher retention and treatment. These are well-conducted studies. They're showing higher abstinence rates and a lack of adverse effects. There's a low risk of oversedation or overdose or euphoria during dose titration. Now, if you do have a patient who's intoxicated or has complex underlying illness, or using benzodiazepine or pines, or has COPD, emphysema, or a decreased respiratory drive, you would cautiously titrate a patient. However, there's an overall low risk of respiratory depression with increasing dosages of buprenorphine. You do want to evaluate the patient history, see if they've been on prior buprenorphine dosages. They may just be a part of a high dose induction protocol. And you want to always verify the dosage with the provider at a higher, when you see these higher milligram per day requirements. But there's some of the literature here about high dose buprenorphine induction in the emergency department for treatment of OUD, and then higher dose buprenorphine associated with treatment retention and low threshold clinics. Now, pharmacists are becoming increasingly confident and collaborative with other providers and other healthcare professionals, especially with OUD and pain management. These issues that we bring up with a provider, it's, we always say, it's for patient care and not to, slow the provider down or to question their diagnostic authority. And some of the useful issues from the provider's viewpoint, we've worked with Dr. Carl Christensen and Dr. Bill Maroney to make a list about useful issues to bring up from the provider's standpoint. They've talked with a cohort of my colleagues and some students, and they said, keep calling us. Some useful things to keep bringing up with us is we may not be aware of co-prescribing of sedatives and stimulants from other providers. Running a MAPS is required, reading it is not. Sometimes you run a MAPS, you don't always hone in and read it. We may not be aware of early fills. We may not be aware of doctor shopping. We may not be aware of a patient's trips to the emergency room for trauma, for overdose, for an overdose, or for a recurrence of withdrawal symptoms. You may see as a pharmacist a patient coming into the pharmacy impaired or inappropriate, sedated, slurring. It's easy. Dr. Christensen said it's easy for when a patient to come and see me every few months to be intact, at their best, but you see them at the pharmacy as they are day to day. Patient could come in with family members that they're sharing medication with. They need to know that as a provider. So family members can get access treatment. Patient is pregnant. Sometimes the pharmacist knows the patient is pregnant before the provider. And there's other areas too that can be useful to inform a provider about that you may see at the pharmacy. Less useful things to bring up would be to call when you get yet another prescription for a patient, a long-term patient. Why is this patient still on buprenorphine? Forced discontinuation of buprenorphine is not supported by current data, and forced discontinuation is associated with recurrence and overdose and return to illicit drug use. I know we're not talking about pain management, though this is another area of practice. With respect to chronic pain management, it's not helpful to contact a provider and ask, why is this patient on X MMEs, like let's say, 100 MMEs of opioid. The CDC guidelines, the revised guidelines for pain, and the HHS 2019 guidelines don't support forced tapers. And the new revised pain guidelines support individualized opioid dosages and flexibility in opioid dosages, and some patients do require above the 50 or 90 milligrams of MME a day. An important point to remember is that we're all dealing with anxious, stigmatized patients, and we need to be aware and compassionate and communicate.
Dr. Tutagler?
Yes, yes.
We are right at 1 o'clock.
Okay, so we will stop right here, but the
Okay.
pharmacy level barriers, they're persistent, and they include anywhere from state to regulations, all the way down to diversion and risk, and fear of crime risk. There's others that we probably didn't touch on today, and I urge you as clinicians to expand your knowledge on OUD management and screening for adolescents and pregnant persons as well. That's an area that is expanding in practice. So I want to thank you, and the future directions are we're going to continue into professional education, continue a pharmacy-driven effort, and an area of that pharmacy is supporting is a buprenorphine collaborative practice with addiction medicine physicians. I have references. I can share these with you after, and these are some photos from the August 31st Opioid
nice.
Awareness Day at
Detroit.
Spirit of America, Detroit. And we had a great turnout. A lot of individuals came for naloxone training. We partnered with Michigan Poison Center, and we distributed naloxone and fentanyl strips. And it was humbling to hear the shared, several individuals shared their lived experiences, and it's never enough what we're doing. So thank you again for sharing this time with us, and I'll be happy to stick around and answer any questions.
Hi, just a question. I'm sorry, my video is not showing up. I just
That's
there we
okay.
go. Oh, it's still dark. So I was the one who asked the question about the Sublocade. Just for some context, I'm working here in Canada, and I was
Yes.
looking at the REMS program. So I was just trying to understand and kind of compare and contrast with Canada and the US.
Yes.
What's going on with Sublocade. And when I read about the x-waiver license being removed, and you were mentioning how there's no longer any educational component, I was just curious about that, because with Sublocade, I know that the prescribers don't need to be certified, but it's
Yes.
more at the pharmacy level that requires
Yes.
certification, right? So that that
Well,
the patients
correct.
are never, so the patients are never getting the product directly.
Yes.
But is there any additional education that's mandated?
There is, the prescriber, I think, has to go and register. The provider has to register that with the there's the FDA link. If you look at the FDA link for the REMS
Okay.
program, I've looked at the pharmacy piece.
Because the pharmacy piece I understand as well. It's just confusing because it says healthcare providers are not required to certify in the REMS to prescribe
No,
Sublocade. So
right,
there's no certification at the prescriber level, right? Like any
right.
prescriber can now prescribe Sublocade. Is that right?
Yes, but they have to go through the specialty pharmacy. You know, and there's some training that's involved, you know, for the sub-Q injection and the monitoring, but that's all provided on the website. And then some, you know what they do? They send a rep out to
Okay.
the clinic.
Okay.
Another thing I wanted to mention too was part of the REMS training for a lot, or not training, but the information for the MOUD agents is included in a safety statement, a recommendation of all opioids. If you go and look at the labeling now for buprenorphine, for naltrexone, for methadone, there's a statement, I think since July of 2021, the FDA requires manufacturers to put this in, that it's recommended co-prescription of naloxone, because even if the individual is receiving MOUD, there is the potential that a recurrence could occur. You know, patient could have a break in therapy and you still, or patient could have adverse opioid effects or sedation from, you know, methadone or from buprenorphine. But even the naltrexone, near the end of the dosage IM regimen, you can have breakthrough cravings and usage. Some patients now are receiving naltrexone IM every 3 weeks.
Okay. Okay. Thank you for pointing that
Right,
out.
but there's that link. If you go under REMS Sublocade, there's that whole link, and then there's, for the US, identify a pharmacy, and there's all these specialty pharmacies registered to
Yes,
provide.
yeah, I see that. I see all that. It was just a little bit confusing because since the x-waiver got removed, so I wasn't sure if, you know, the educational piece, like if any prescribers could still just write the prescription, and then it's at the, like, you know, it's at the level of the pharmacy to have the certification.
Right, and then the issue is too that the DEA 8-hour training,
Yeah,
you know, that's that 8-hour training, encouraging everyone with a controlled substance license in the states to become familiar with all the forms of OUD treatment, and hopefully, you know, that will move people to that as well.
for sure.
I don't know how much, you know, pregnancy is really covered in there too, you know, and SAMHSA's website is useful as well. I always go back to the SAMHSA website.
Okay. Yeah, it was just a little unclear as to what was mandatory training though for Sublocade,
Oh,
you know, just because
no.
it's that injection and there is
The
that
manufacturer
danger.
will come out
Yeah.
and
Yeah.
they'll run out and help you. You know, they'll send out their reps in full force.
Right. Okay. Okay, great. Thanks so much.
Thank you.
Have a great day.
You
You
too.
too. Thank you.
Thanks.
I believe all those QR codes expire within 48 hours. So please take a moment to get those done and filled out. We want to thank Dr. Tutagler so much for
Thank
being
you.
here with the Michigan Opioid Collaborative and for sharing this wonderful information. You'll be receiving an email from your behavioral health consultant with the Michigan Opioid Collaborative. So if you or your agency would like us to do an in-house presentation, or if you have other questions, or if your providers in your office would like to sign up with us for our free same-day patient consultation services, we would love to chat with all of you to make that happen as well. So we're going to hang out for a minute to tidy up some last minute Zoom things. So if you have any other questions, feel free to throw them in the chat or to just shout them out, unmute yourself. And again, thank you all so much for being here today.
Thank you very much.
You.
Thank you. Thank you. I appreciate this.